Thank you, Sergio and Paves, for inviting me to this interesting day, especially the morning also. I'm going to expand a little about the neurophysiological characterization of chronic post-herniorrhaphy pain. And the questions I got from the organizing committee was, first, what is the definition of neuropathic versus inflammatory pain in these patients? What is the interval between the repair and the development of chronic pain? And next one, pharmacological versus surgical treatment of pain. And finally, what is the method of follow-up? All quite difficult questions to answer. Now, if we go to the real experts on neuropathic pain, they have a consensus paper which is available as an EPUB publication. And the only thing they really can come up with is that neuropathic pain is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. That is a rather vague, unspecific definition, I think, and especially in hernia surgery or any other persistent post-surgical pain state where we have nerve lesions, this will not help us very much. Now, some of the well-known international neuropathic pain researchers, they looked at some groups of patients where they said the clinical symptoms should be a neuropathic pain state or something where they suspected it or something where they thought it was unlikely. And they looked at different usual pain descriptors, including those that Mike showed you, and they concluded in this paper, and I think you should read it, pain descriptors are unspecific for this. That means that if you have a chronic pain patient after hernia operation, you cannot say for sure, based on these pain descriptors, whether it is a neuropathic pain or a somatic pain, nociceptive pain. But if you have 200 patients, you can probably say something in general about the groups. Touch and cold provoke pain and brush-evoked allodynia is more prominent in neuropathic versus non-neuropathic pain, but with a considerable overlap, again unspecific in the individual patient. So conclusion was clinical diagnosis of neuropathic pain is not well defined. So that already starts the discussion here that it will be difficult for us in our hernia patients to say, are they belonging to one group or another group? So let's take a look at the hernia literature on signs of nerve damage. And the first one was really the Cunningham study many years ago. In fact, the first real study that had a focus on chronic pain. And we have at least 10 articles after that reporting some numbness or sensory dysfunction. And the problem is that not a single of these reports have a very detailed methodology section. And no neurophysiologist interested in chronic neuropathic pain would accept the methodology in all these hernia studies. And especially, there is no QST studies, that means quantitative sensory testing, a well-defined equipment that is used to assess these patients with chronic neuropathic pain. So we did this study, and you can in fact find it on the website of the Journal of Pain now. And we took 45 patients with really severe chronic pain from the Danish hernia database and compared it with 10 pain-free patients. Some of these also had bilateral herniorrhaphies where they only had pain on one side. And then they were assessed with this detailed well-defined equipment to measure sensory threshold, also for pinprick, with von Freiher's, with cold, with heat, and with a pressure algometer, and also to map out what was the area of sensory dysfunction, and then to compare it also on the non-operated side. And to make a very long story short, the conclusion was that cutaneous sensory deficits have a very low specificity for chronic pain. That means that a lot of the patients without chronic pain have sensory dysfunction. That means that they have a nerve lesion induced by the operation, but they don't end up with a chronic pain state. So a nerve lesion may be a prerequisite for going into a chronic pain state, but there are many other factors that determines whether you end there or not. All pain patients had sensory deficits, but it's a very unspecific sign. But the interesting thing was that positive sensory abnormalities, and that is the wind-up phenomenon. That means that if you have repetitive stimuli with pinprick or with a brush or with a heat stimulus, these patients, they build up pain and it gets extremely severe pain just to an innocent stimulation. And also the allodynia thing was found in this group with chronic pain, but not in all of them. It depends on the stimulus type. Between 10 and 45% of these patients had these specific signs that you alluded to was characteristic of neuropathic pain. So if we believe that, it's only about 25% of the pain patients with a nerve lesion who completes to your definition of neuropathic pain. And that makes it very difficult again. So the key question here to understand the neurophysiology, and that will help us to design the prevention or the treatment of these patients. The question is, what is the relative role of intrinsic properties in the central neurons following a nerve damage? The spinal cord physiology with hypersensitivity, etc., versus an excessive drive from the hyperexcitable peripheral afferents due to the inflammation from the mesh. Because we all know from reoperations that you have an inflammation going on if you have a mesh, more or less depending on the type of mesh, but you have it. So really we don't know, and therefore we cannot separate clearly in these patients, is it a nociceptive pain or a neuropathic pain? So it's really complicated in these patients. If we start up here, you have the chronic pain patients, but we know that inflammation can contribute to that. We know from several studies that if the patients have pain in other parts of the body before the operation, that could be headache or low back pain, they have a much higher risk of ending up with a chronic pain state. This has also been shown from other operations like thoracotomy or mastectomy, where you also have nerve damage. They can, of course, have other diseases mimicking chronic neuropathic, chronic post-herniorrhaphy pain. And then they can have a hyperactive nociceptive system, and that comes into all the pain genes. And we know that we can predict the intensity of the acute as well as the chronic pain by just giving a heat stimulus before the operation, and you can see the different responses in pain between different patients. And those who have the highest pain rating to this preoperative heat stimulation, they are also the ones who have the higher postoperative pain responses. So there is something in the genes here that determines the end result. But of course we have this more clear group here where we have different well-defined nerve damage, and then we will end up in the neuropathic pain state. But how these circles are intermingled, we simply don't know. So the first question was, neuropathic pain requires demonstration of a nerve lesion. Nothing new in that. It doesn't help us. Classical clinical signs, symptoms of neuropathic pain are unspecific, including in our chronic post-herniorrhaphy pain patients. How many patients have a nerve lesion without chronic pain? Probably in the range of 40% or so. What is the diagnosis of inflammatory pain? I think at this time we simply cannot tell. We have no specific signs of a chronic nociceptive pain due to the inflammation from the mesh.